Welcome to the Next Orbit podcast, where connecting healthcare's data is the next frontier. We take you inside conversations with policymakers, healthcare leaders, disruptors, and visionaries who are pushing boundaries in a system that resists change. This is your launchpad. Here is your host, Ben Wade.
Hi, welcome to another episode of the Next Orbit podcast. My guest today is a chief compliance officer, but he's not just another corporate suit. Before pursuing a degree in law and ultimately becoming a chief compliance officer, he started as a first responder in Oakland, which says enough there. He's got a significant experience in the FQHC space, where he was the CCO of one of the largest FQHC networks in Southern California, and also ran one of the largest PACE programs in the country, which is for the elderly. But he's specifically written about the use of AI to solve pajama time, a name that's synonymous with physician burnout. So please help me in welcoming an AI optimistic CCO to the show. Robert Colin-Torres, thank you for being here.
Thank you.
Thank you. Good morning to you both from not so sunny California. It's kind of gloomy out there.
So Robert, you've written that the question of isn't if we should adopt AI, but how fast we should adopt AI. For a role traditionally called the office of no, that is a radical stance. Was there a specific moment or a specific event that flipped that switch for you?
Yeah, we spoke, I think it was a week ago. I'm an 80s kid, and so I love technology. When the earpieces came out, I remember getting a big earpiece and looking like a cyborg. But it's really how we can partner with technology to make our lives better. But kind of getting to your question, I noticed that our department, as you said, oftentimes people say the Department of No was being left out of these crucial meetings. So started noticing that other departments in our healthcare system was trying to integrate AI as part of our daily operations without considering the crucial factors, which how can we safely integrate AI into our daily operations while protecting patient information, while protecting work product? That's a question that wasn't being asked. Who does the work product belong to? Where is it being stored? How is it being protected, and for how long? And so, to kind of bring my department into the mix, if you will, I wrote this article from my perspective as a CCO, saying that it's really a couple of things. It's not a matter of time. AI in healthcare is here; it's happening already. Two, let's do it, but let's do it responsibly. Let's do it together as an organization. And kind of work out all the different bugs to make sure that it's going to benefit our organization, but more importantly, our patients. Everything is about how can we provide smoother, more effective patient care while protecting their information, while having a good understanding of the applications that we're using. And so that was the other thing. I called for timeout. Let's get some understanding around this. We can't just the vendors will show up. It sounds great, but let's stop and think about what's going to be the policy around this. What's going to be the use? How are we going to train our employees? We can't just plop them in and say, hey, here's some new technology, figure it out. Although I know there was that joke of like in the 80s, we throw out the instructions for the BCR. I never went to anyone's house where the BCR time was set. It's true. We throw out the instructions. We're like, I'll figure it out. Well, we can't do that with AI in healthcare. We have to read the instructions. We have to see how it's relevant, how we could do this responsibly. And so that's the main reason for this article, is to show my support for AI in healthcare, but also say, again, I see the benefits, but let's dial it back until we can understand this a little bit more.
Well, I think that's why me and Mike found you to be unique in terms of a chief compliance officer. In your role, CCOs usually view risk as legal exposure or jump to thinking about data breaches. But you've argued that physician burnout is also a compliance risk. How do you calculate the risk of AI versus the risk of an exhausted physician making a human error?
Yeah, I'm sure your listeners are probably familiar with the term pajama time. A lot
Right.
of providers will go home after work and they spend an additional 8 to 10 hours a week working on documentation, and that's time they can spend on resting or working out or time with their family. And so, from the perspective as a former first responder, it was concerning to me because we want to prevent provider burnout. Providers are, they're a main part of our organization, right? Without providers, well, what do you have? You have the compliance department. I'm joking, but my concern was for the well-being of our providers. What can we do to reduce the amount of time of after work tasks? A good friend of mine is a provider here in Sacramento, and we've had this conversation before. He spends time on the weekend instead of with his kids catching up on his notes. Using AI transcription, that'll reduce that amount of time greatly, 50 to 70%. It'll reduce that amount of time. Well, so people like my friend can go out and spend time with their kid or their kids. And I think that's huge.
Can I ask a question there, Ben? You might be getting into this, and if you are, you can be like, Mike, let's wait. But Rob, that kind of leads into an area because you have that expertise in compliance, that I'd love to hear your thoughts on, which is if you're a lot of people are thinking about ambient AI and how that can be used to reduce the burden on clinicians and give them some of their time back, which is fantastic. On the flip side, as you know, and you've already indicated when you said there needs to be a pause, and let's talk about this, there are risks. As you said, where's the data going to reside? How is the data going to be used? Like secondarily, are there going to be secondary data uses? What kind of guardrails do you think people need to consider around these kinds of things? Like if that data is going to be captured and there are going to be, like, should secondary uses be allowed? In what cases? Like, how do you make those decisions?
Yeah, that's a great question. I was shocked when we finally got invited to the table, and I asked what I thought pretty simple questions, which to me is very important. Again, who owns the work product? I wasn't getting any answers from either side. And again, where is it stored? How is it used? Is it going to be used for anything else? Because we got to figure out, do we need to extend patient consent for that data to be used for, I don't know, selling health-related products that could be beneficial to the patient, but the important thing is not creating a data breach or not creating any type of HIPAA violations.
Right.
How can we do that? And so those were some of the questions that I brought to the table. I think all that can be done, again, by stepping back and taking a closer look and asking those simple conversations amongst yourselves, what I mean your organization, and speaking with the vendor. How is this information stored? Is it yours or ours? Put it in the contract. Clearly put it in the contract who that work product belongs to and how is it stored. What's the safety mechanism around that? Is that ever audited? So it's a cloud-based storage. How is that audited? What's the protection around that? How often is it updated? These are all relevant questions because in the future we're going to start seeing some of those cloud-based storage systems being breached. It's only a matter of time. I mean, we hear about healthcare systems getting cyber attacked all the time. It's only a matter of time before that happens. Well, you got to ask those questions up front and address them.
Yeah, I've seen very sophisticated recently attacks on. Everybody knows that the kind of the end user is the weakest point in security, and phishing and whaling attacks that have become very sophisticated because of AI. In fact, I think you're right. We're going to see that's a that's a it's not so much a prediction as just something that we all need to be aware of, that things are going to happen. Um, One of the things that I wanted to acknowledge is, as kind of a technology person, I myself, when you asked that question, realized I wasn't considering that. And I say that because I think that
Same.
it is easy when you're coming from the let's build it side of things to be like, okay, we kind of figured this out. We know what we need. And when people start to say, well, hold on a minute, you don't want to pause, because the energy is all moving towards implementation and value realization. And what I hear you saying, and I just want to restate it, and then I'd love to hear if you want to add anything to that, is just that when it comes to these kind of leading edge or bleeding edge technologies, there are great opportunities, but the risks are less well known. And often, because they're less well known, people who aren't used to thinking about risk, like myself, may gloss over something that could actually lead to complete destruction of that value. If you have a serious breach, or your patients learn that data is being used in a way that they never consented to, you may have to tear that whole system out just to rectify things, and that would remove the value to your providers. So I see high value in what you're doing right now is all I wanted to say. And that it's the fact that you're not a yes man, but a yes, or not a no man, but a yes and man, is really great.
Yeah, I'm so excited to see what we're going to use AI for in the future. That's the other thing. I wanted to be a part of it from the beginning. And in order to do that, you have to have understanding. You can't just kind of fumble through, guess. And so when I go to the table and we have IT or we have an AI vendor, to be able to speak the language enough that they're like, oh, okay, this guy knows. He's not, some middle-aged CCO showing up asking, questions that don't matter. He's asking relevant questions, and he kind of speaks the language a little bit. So, and it's been beneficial.
Well, Mike, you jumped right into the scaries, which I do have a few other questions around later, but I also wanted to touch on your experience working with federally qualified health centers. So you've worked serving some of the most underserved populations, and I think a common conception is that, or misconception is that, people assume AI is a luxury for wealthy hospital systems or for larger health systems. But you've implemented it at an FQHC. So just how are you seeing AI leveling the playing field for community health centers that are historically under resourced?
Yeah, that's a great question. Implemented it already at one FQ. We call them FQs just for short. And at my current FQ, I'm working on implementing AI here as well. The beauty of it is that the price for AI applications has come down substantially. And we've been able to find vendor partners that we can afford, because it's important to, while we're FQs and we do, as you say, support and provide care to some of the poorest in our communities, we also want to be competitive. We want to be a competitive healthcare system. We also want to, again, as I mentioned earlier, we want to provide effective healthcare. And these are all the tools of the trade that we need to do so. So it really hasn't been that difficult to integrate it into an FQ. When I reach out to my partners and some of the bigger healthcare systems, Kaiser and Sutter Health around here, we're facing a lot of the same issues as they are, as far as comprehension, as far as knowing what questions to ask. And so I wasn't surprised about that, but I was surprised about the affordability, really, because I thought that, this is going to be something, this is a luxury that we're not going to be able to afford. But the prices they've come down. That again, FQs can afford them, and it's making the FQ world much better for not only staff, but also for patients.
And again, specific to the FQ space, when you implement an AI tool such as ambient listening or transcription tool in a community health setting, how do you handle the trust factor there? Do patients react differently in those settings when they learn an AI is listening to the consult, or how do you script that conversation with the patients for your providers?
Yeah, that's a great point. Um, at the last FQ I was at, we kind of scripted it out so that the front desk people, while the patients are signing the consent forms, they're able to explain it in a very clear way of how this is beneficial, but also giving them the option of opting out. We always gave them the option of opting out, and I think that made the big difference. We never had anyone opt out. Everyone sounded excited and looking forward to it. But I think that if we took that away from them and made it that this is just how it is, that they would have created some sort of, I don't want to say backlash, but some, reluctance. But it's really the way that you explain it to patients, and that's a skill set, because you can't explain it to the patient population the same way that you would maybe to your guests or your listeners. It's got to be in a very basic way, but hitting all the key points. And the bottom line is, again, that you can opt out, and we could do this the old-fashioned way, but this is how it's going to be beneficial for you. This is how it's going to be beneficial for your healthcare. It's going to be beneficial for your provider, and never really seen a lot of pushback at all. In fact, people were they were excited about it. I think I had mentioned earlier I was an 80s kid and just loved technology. Which is funny. I never went into IT, but maybe the next lifetime. But I think there's a little bit of geek in all of us, a little nerd in all of us that are like, oh, that sounds cool. So people have been at the very least interested.
That's great to hear, and glad to hear that it's happening across the board, even in FQs and rural settings, not just your large academic hospitals. Mike, I think we've laid some groundwork here. If you want to get back to touching on Rob's anxieties, I'm ready to move back in that direction.
Well, it's not so much anxieties as I think, again, we talked about risk-based decision making is a factor, particularly when you get closer to the edge of things. When things aren't well understood by everyone who's involved, then it's important that we have frameworks that help us kind of evaluate the cost, value, risk ratios, so that we understand, oh, great, this is something we can afford. It has a lot of features that we like, so the value is high, but we aren't as familiar with it. So what are some of the risks we need to consider? I think for me, I guess kind of the questions that come to mind, I'm thinking about the implementations that you've done already, Rob. What are kind of the lessons learned from the recent, the most recent, the one that you did with the last FQ? What lessons might you have from that you would offer to, a healthcare leader who's contemplating how do we implement something like this in a valuable but also safe and acceptable to our patients way? I mean, I like what you said about the fact that people could opt out, and that even though you didn't have anyone opt out, what you gave them was the autonomy to decide if they wanted to be a part of this. Are there principles like that you think that from your experience and also from your training that you would recommend these leaders think about? What are these principles or potential lessons learned that they ought to consider as they're thinking about this?
Yeah, I think developing the ability to clearly convey to not only patients but their family or anyone out in the community that reaches out to them, as well as their staff, just being able to explain how this technology is beneficial. But really what was important for me really was to partner up with the compliance department of the vendor. I wanted to connect with them. So that's one of my pieces of advice is for them to have the compliance department connect with the vendor's compliance department because we speak the same language. And a couple of flags for me were that if they can't answer it from a compliance perspective, that's concerning. The questions I had already posed. How is the data protected, essentially? How is it audited? Those important questions, because that's also going to help you develop your internal audit tool. You got to audit these systems. You got to partner up with IT to make sure that there isn't any kind of that the data integrity is intact, that there aren't outside players or actors accessing that information. And in order to do that, again, you have to know the different aspects of it to build out your compliance program or your risk program or what have you. So part of our internal system that we did once we gained basic understanding by partnering up with the compliance department for the vendor was how to develop our own internal audit tool. And it's essentially always going to be the same thing, whether you're looking at EHR, it's going to function the same way, really, which is essentially, has any bad actors been able to get into our system, infiltrate our system? If so, what's the forensics on that? And these are all important things to have developed, is that audit tool, and have staff trained. You got to train your staff. It's one thing developing an audit tool, and another thing, can your compliance staff or risk or what have you, quality staff actually use these tools? And I'm also in support. In fact, I push my employees all the time to go take a certification or training in AI. And look, I know it costs money, but my thing is, I'll spend $2,000 to send you to a training because it's a lot cheaper than the 15,000 that you can get fined by the government. So to me, that's a savings. And oftentimes when they come back from these classes or these credentials, they're also able to kind of expand and make the audit tool even more robust, because they're like, well, we learned this and this, and we're able to add that onto our audit tool. And also, I would recommend that reach out to the vendor compliance department and see if they will provide you copies of their audits. They should be doing audits as well, whether it's quarterly or annually or what have you. They should be able to provide that to you, that, look, we haven't had any infiltration into our cloud system. Therefore, we haven't had any kind of breaches. So these are all important things to consider.
So it sounds like your audit tool is specifically geared towards data breaches and security, but as a chief compliance officer, your job is to control other variables besides that. Well, AI models are often black boxed, as you know, where the user doesn't fully understand the output that's been generated. How do you get comfortable legally and ethically signing off on a tool that you can't fully predict?
Again, trying to have as much understanding about it as you can.
Okay.
It's sort of a fool's errand to sign off on it if you don't understand how it operates. If you don't understand the legality around it. I think once you do, you're able to be a little more comfortable in working with that. Again, I have colleagues that they never thought about it, but their healthcare systems have now implemented AI, but yet they have no idea like the legality around it. They have no idea of how these things function.
And is that something that working with chief compliance officers at the vendors, at the vendor level, are they helping you understand how different information is outputted or generated to get you more comfortable with that?
I found that a lot of the vendors are more than happy to take time out to essentially educate you on how their systems operate. And so again, that's been very beneficial for us to create our audit tools. That's been very beneficial for us to create staff training. Again, you got to train your staff on how to use these applications. You can't really fall back on like, okay, the AI transcription will do its thing. They need to have a little more understanding of that than just, press play, Um, and so, but yeah, the majority of vendors I've dealt with professionally, they're more than happy to take a couple of minutes out and educate you on that or provide you the literature on that, or like I said, in a lot of ways, even help you develop your own audit tools because they understand, yeah, you're going to have something in place to show that patient data, the integrity is being protected. And so they're more than happy to do that. In fact, it was mentioned to me like, look, we never thought about it from your perspective. So when we started collaborating, they were curious to learn about how we operate, how things operate from our perspective, from our end, if you will. And it was a great learning experience. And one of the gentlemen I worked with, he was saying, look, I now feel like I have the skill set when I work with other FQs. I feel that I could be able to relate to them and kind of put them at ease because I understand where you're coming from now.
I think that's
jump in,
great.
Ben?
Oh, go ahead, Mike.
Sorry, because that does lead to something that I wanted to kind of understand. You had mentioned again, and this is, I think in the world today of AI, we have the reality of there's a lot of people jumping in who, and you just mentioned like this helped them as well. It was mutually beneficial to have the conversation because then they could think about the FQ's perspective. So I don't want to say that people are, pure snake oil, although I'm sure there probably are some snake oil salesmen out there.
Yeah, they're still out there.
But a solid solution, people, the difference between a snake oil and solid solution is vast. But in the time when everybody's learning, most of them are going to be, they're not going to be true snake oil, but they might accidentally be more in that direction because of their lack of understanding.
Mhm.
I know in healthcare that, data and the way it's used is very controlled, and you know that even better than I do. And yet, in the world of technology and kind of the innovative side of things coming out of Silicon Valley, and that thinking is like, let's move fast and break things so that we can learn as we go and get things done and get to the value faster. One of those areas where that's shown up, as we know with these models, is in the training data. There's still questions about, what should or shouldn't be allowed with data that's perceived to be public data. Clearly, your health data is not public data, but once you start sharing data and I want to improve my model, I'm going to have an incentive to try to use that data for improving my models. How do you deal with that? Have you had to deal with that in the conversations with the vendors that you've dealt with? And if so, how do you deal with that? What do you want to know from them in order to understand whether or not this is a thing that would make sense to say sure, or where you'd say no in all cases? I don't know as a compliance person what your perspective would be on that. So I'd love to hear it.
Yeah, that's a really great question. I think from the very beginning, you got to clearly define what's acceptable and put it in that contract. Make it ironclad. If you're not comfortable and it doesn't adhere to state or federal regulations, you can't have a situation where they can now use that work product to target patients with diabetes or you know sell them DME, durable medical equipment, based on, hey, we got this pool here that we can pull from this data. We got this pool. We could target these individuals for specific things. You got to consider the ethics of that, if you will, and what you're comfortable with, because it is your responsibility to also convey that to the patient that, hey, your data, they may use your data to reach out to you. Let's look at it in a way of everyone's trying to be a good guy or a good person. Look, we all want to help the patient, so let's take the profits out of it. Um, I get that, that's fine, but we gotta make sure that the patients are aware that these individuals may reach out to them. Now, when you factor in the money, there's the incentive of, again, isolating these populations and reaching out to them. Got to make it very clear. Got to make it very clear to the vendor partner as well as patients. Hey, they may reach out to you. Do you give consent for AI to be used during this visit? And so, again, just got to be very, very clear about it. Make sure the lines are drawn clearly, because if it's a little bit gray area or the lines are very just blurred, that's where you run into legal and ethical issues that could backfire.
So if I restate it, it sounds like, again, coming back to consent, you just need to be clear about what they're consenting to. So if there are additional, potentially from a patient perspective, but certainly from the vendor perspective, value added services, that they know that that's something that they have the option to consent or opt out. So maybe I just want you to be able to use the ambient AI, but just for my care, and I don't care to have any further contact from the vendor or others who might use the vendor's data. So you're opting out of that, and my data won't be used for those purposes. Is that kind of the point you're making here, Rob? Just to make sure I'm understanding. Sometimes I'm a simpleton, so I like to.
Yeah, that's part of the point. But really, as a healthcare system, as an organization, you got to decide what is it you feel comfortable with.
Okay.
Because I know there are healthcare systems out there that are 100% no. This pool of information cannot be used for targeting specific patient needs. Again, with the DMEs or diabetic patients or study groups or anything like that. But as an organization, if you decide to share this pool or allow this pool to be used, you got to make it very, very clear to the patients. You got to make it very clear verbally as well as in your consent form. They got to know what they're signing up for. That way they have the educated option to say, no, I'm not comfortable with this, or like, yeah, it sounds great, whatever. They might reach out to me in a couple of months and they might try to offer me a smart glucometer, and that sounds pretty cool. It's again, what your organization is comfortable with, but also at the very end, making sure that the patient, that they have a say in it, that they could say no, or they could say yeah.
Yeah. The last thing I have here is just on that is that I know, I feel like with model training and with the emergence of machine learning, that some of the things that we used to consider research have started to fall into a gray area, right? Like is this something that you do to maintain an operational AI system that can support with decision making, clinical decision support, or recording and helping with those kinds of things, or is it becoming more of a research project? And I'm sure there are much more educated people. Maybe we'll have one as a guest, or maybe yourself, who will come in and tell me well, here's how we distinguish that now. But I guess that is part of my question. How do you consider that? And for an FQ, I don't know if they also, because I don't operate FQs, I'm just familiar with them from the outside. But if they have an IRB and how that would be involved, what are your if you could just kind of educate me, make me personally a little smarter, and hopefully some of our listeners on those thoughts.
Can you rephrase the question a little bit?
Yeah, let me rephrase. So I think what I've started to sense is that, there's always been a kind of a line between healthcare research and then the delivery of healthcare. And often you'd have an IRB that looks at things and makes decisions about, how data can be used and what research can be performed. And by IRB, I mean the Independent Review Board, for those who might not be as familiar. On the flip side, though, with more and more of training of models and AI and vendors who might want you to opt in and say, hey, can I use this data to make my model better? Not necessarily even to sell to the patient, but just to improve the performance of the model. How does that play with research? Like, when do you start to consider that something that has to be considered by like an RIRB or a similar kind of body?
Um,
Or has that even been established? Is that still an open question? That's okay. I just
yes,
curious.
yes and no. Yes and no. It is still part research. You gotta keep that in mind. It helps you stay current. So it's still part research, but um, it's a good way to educate yourself, educate the organization. But for a lot of healthcare systems that I'm in contact with, they're still trying to figure out how to balance that. Um, how okay, we have a great understanding of this. We've done the research. We have folks who are actually um, getting credentials or degrees. I had an employee at my last job was actually studying AI, and but really it seems like across the systems, the different healthcare systems, that they're still kind of figuring it out.
Okay, that's fair. I mean, we are. It's been out a few years, but that doesn't mean it's gone everywhere yet, and we're learning as we go. So, yeah, I'd love to see kind of where that starts to land as people get a deeper understanding of it. So, thank you.
Yeah. Maybe 5 years from now we could do a follow up and like, well,
That'd be awesome. That'd be great.
This is what's happened in 5 years.
So Robert, I think we're aligned in that we're optimistic about different AI tools and their impact on the healthcare system. But I would say with one caveat, and that's that Mike and I both strongly believe, at least in the early years here, that there should always be a human in the loop. So we've talked about AI reducing pajama time or provider burnout, but if an AI tool makes a mistake or an error in the medical record, the liability still sits with the human or the physician.
Absolutely.
So how do you train your doctors who this may be something new to them? How do you train them to stop treating AI like a magic wand and start treating it like a junior resident or an assistant who needs their work to be checked?
I love that. It's a great question. I also love the nature of providers. They are, by nature of what they do and by caution, very prudent and I don't want to say suspicious people, but just like they would review the work of a resident, the providers that I've dealt with don't have 100% trust yet of AI. So they do go back, they've caught mistakes, which then leads them to, hey, I got to check even more. So it's sort of become a built-in system. Once you remind providers or staff or whoever's using this technology that, again, errors can occur. But as you said, we're responsible for the errors, whether it's legal sanction or what have you. We're responsible for these errors. So making that crystal clear, but then also providers and other staff seeing these mistakes happening in real time has created a sort of a feedback loop system of where they are going to confirm work. I don't know a single provider that hasn't done that. They're happy, of course, when things look great, but they're also they feel reassured when they catch these errors because I'm still doing my job. I'm still making sure that I'm treating this as a tool and not so much that it's a magic wand that's 100% perfect, that's 100% accurate. I mean, look, anyone who's ever used Siri,
Yeah.
you know what I mean? Like my dad just called me out of the blue the other day. He's like, "Hi, darling." I'm like, "What?" He's like, "Read your text message to me," and I read it, and I was trying to say, "Hi, Dad," but Siri put "Hi, darling," and so kind of the same thing when you stop and think like, let me confirm what this transcription tool has recorded. So that really hasn't been an issue. It really hasn't.
All right, Mike, if you don't have any other questions, I have one looking into the future.
Yeah, no, please go to your questions.
Yes. So I want to know where the next green light is for you, Rob. Right now I think we've talked about, you're bullish on AI for transcription and for documentation purposes and giving time back to the providers. But what's the next frontier where you're ready to give the green light for a different technology, for a different utilization case? Is it, have you thought about diagnostics, revenue cycle, or maybe something else entirely?
Revenue cycle has been on my mind lately. But the one thing is that we started integrating a beta program at my last job was smart glucometers.
Mm.
Mm.
Partner up with EHR systems. And so, your providers can see real-time data of, oh, hey, his blood sugar is substantially high. Let me reach out to this individual. And we discussed it, well, how do you set that? When we had the pre-podcast conversation, we discussed that in order to do that, because you can have fluctuations or glitches, yet you got to kind of, that first week or two, develop an average of that person's blood sugar. But anyway, being able to get that data in real time and make sure that that patient is being treated, or that they're aware that their blood sugar is too high, too low, really fascinates me. And unfortunately, at my last job, like I said, we got it to the beta point, but I would love to see that fully integrated into our healthcare system. In fact, I was talking to a provider here a couple of days ago. At the last healthcare system she worked at, they fully integrated these smart glucometers. And so when I heard that, of course, I had to reach out to her. I'm like, how did it go? Like, it sounded like it went really well, but again, you have you're still going to have your basic concerns of protecting data. That's going to be the biggest thing, is protecting data, ensuring that staff they're competent enough, that you're providing them that competency, so they can utilize these tools effectively. They can utilize these tools in a way that doesn't conflict with state or federal laws, doesn't create any ethical considerations. And so that is the next thing for me, is these data glucometers. That's really the direction I'd like to push us.
And those glucometers are the tools that are being deployed. Is it just to find anomalies, or not anomalies, but maybe spikes in sugar in the data? And is there is it an element of a voice agent or someone that reaches out to the patient and drives them into the office, or is it providing patient education back to the patient in real time to help them lower their blood sugar? Or how does the AI work in those scenarios, those tools?
Sure. So the function of AI in this specific area is to provide comprehensive data to the provider. Oftentimes patients will use the glucometer. Some of them will store that information, but it's not really being shared with the healthcare provider. Now, you go in, they do a finger stick, they get your blood sugar, they have the idea of like what your blood sugar is at that point. But this provides long-term tracking of someone's blood sugar, which will allow that provider or providers to provide effective patient care. It may be a matter of let's switch what medication you're on. Let's take a closer look at your diet. Let's take a closer look at other medications that you're on that might be affecting this blood sugar. Now, as far as contacting the patient, it'll usually be the provider that'll reach out and say, hey, Ben or Mike, I noticed your last blood sugar reading was a little bit high. Are you taking your medication? Are you out of medication? And that's a great thing. Are you out of medication? Yeah, I am. I've been out of medication for a couple of days, and I just haven't had the time to reach out to you. And they can fill that prescription, put in a prescription for that individual, and get them back on course to control their blood sugar. So it's a beautiful, amazing tool that provides, again, real-time healthcare treatment rather than, again, people's blood sugars, they fluctuate. Well, providers only seeing what they see when you come in, and that's not really the big picture. But if we're looking at the course of a week or a month, they could look at that data and, hey, well, we did that medication change a month ago, and we're looking at the data since then, and your blood sugar has substantially been stable since we did that. And this is a great thing. So again, it's just another tool to provide effective patient care. And that's really what it comes down to, is providing effective patient care, making it easier for healthcare systems to partner up with patients to ensure that they get that care. And for patients in our world who often don't have other options, it's a great thing. It really is that, hey, these people are reaching out to me. I've been out of medication for the past few weeks. They're reaching out to me, and they want to make sure that I'm taken care of, and it's a great thing. It really is.
So, Rob, I know we've had a great conversation here, but you also offer support in some adjacent areas, and I'd really love to talk a bit about that and hear about kind of the consulting or the things that you can offer people based on your experience in these other areas.
Yeah, thank you, Mike and Ben. I appreciate that. My career in compliance and healthcare has been pretty broad. Prior to becoming a CCO, I was working for an organization that was branching out to California from New York. They've been in New York providing assistance to individuals with intellectual disabilities in New York since like 1950 something. I think it was 58. So they were starting to branch out to California, and they needed to have expertise in quality and compliance related to residential programs in California. And so there's just a lot of regulations around that. There's the Lanterman Act, which is sort of the, I don't want to say like the constitution for that industry. And so I spent several years working with this organization to ensure that their compliance program was, effective, that it met the regulations for the state of California, as well as the rights guaranteed in the Lanterman Act. And so having that expertise, I also know during the course of that time that there's a lot of good people out there that want to develop these homes in different parts of the state or the country, really. But they don't know, they have no idea how to do it. It's because it is pretty complicated. The proposal, several hundred pages long. You're essentially writing the demographic part of this is a 4-bedroom home located in the city of San Diego. There's a school 3 minutes away. So you've really got to create that demographic. That part is easy, but now you got to delve into the operational stuff, the daily operation stuff, the auditing. These homes are heavily regulated, and I'm so happy about that, because somebody's child, somebody's brother, someone's sister, they live in these places, and it should be the best place where they can live. Yeah. And I got to say, the organization I worked for, the homes were beautiful, but in order to ensure that they're safe, you got to have audit tools in place. You got to have an audit schedule in place. So that's part of what I offer, is to, again, not only help them develop the proposal, but also to develop audit tools, to develop audit systems. Again, you can write stuff on paper, and if you're not doing it effectively or don't know how to do it, it's useless. And also giving them the option that I can come in and do the audit myself in person, or one of my colleagues can come in and do it, or we could do it virtually. So there's that aspect of what my consulting group is doing, as well as okay, the healthcare side. As we were saying off break during the break, there's a lot of mom and pop clinics out there that need to be competitive, that they need to have that they need to adhere to state and federal requirements when
Right.
it comes to risk or quality or compliance in order to avoid heavy sanctions. The fact that they've been operating under the radar or they didn't know, it's not an excuse, unfortunately. So I offer that same thing, online consulting or in person. It's not a problem. We can come through quarterly and essentially do the audit for you, acting as your compliance and quality department, um, depending on what their needs are. Sometimes it's just a matter of like, we have a brand new team here. They have no idea how to do this. Can you come in and train them? And that's not a problem. We'll go in, we'll train them, we'll make sure that they have all the audit tools that they need. Sometimes it's a matter of we can't afford to have an in-house compliance department, or it's one person. I dealt with an organization where it was essentially one person, and they needed support, and so we offer all that. In the future, we're also going to be offering compliance programs for AI related,
Mm.
applications or DME. But we're not quite there yet. So
Well, that's great. If people are interested in connecting with you about that, how can they get in touch with you, Rob?
yeah, they could reach out to the RPCT consulting group, and I will give you. Let me pull up our email address here real quick. But if they put in RPCT consulting group, Lanterman Act, or residential programs, or compliance, it should pop up. So
Okay, that's great. And I just have to say, kind of on a personal note, I have a daughter who works in with the special needs community in high schools. It's something that she felt called to do it, and something that she cares about deeply. And so, knowing that you're out there helping to ensure that from the other side of things, that people who need residential care are able to get into places where they can get that care in a safe and loving way. That's great. Really appreciate that.
and I'm sure she loves what she does. I found the majority of people in that area, in that field, are compassionate and loving people, and I loved working with them. And I also love all the different requirements that the Lanterman Act requires. I remember being in my office, essentially writing a policy for, it's called P&I, and it's essentially allowance money for these individuals that live there, and writing, that they have the right to go on trips, to go on camping trips, to go on day trips, and I'm sitting there in this office thinking like, I want to go camping too, and I'm like, yeah, this sounds great, but that's the thing. That's one of the things I felt in love about that was reading the Lanterman Act, and it's the idea is to make sure that they have the most optimal life possible. And I absolutely love that. And so that's why, although I'm more, my expertise is more compliance related to the healthcare side, a part of me wanted to continue doing that because there's just a lot of good people out there that need that support. And, I just enjoy interacting with them, working with them. And every once in a while, I do have someone that's, hey, my son has special needs, or, this kid at church has special needs, and love what you do. And it makes me feel great. And that's why I got into healthcare in the first place. Um, and, it's just been an amazing journey for the past, oh, wow, I'm getting old, for the past several decades now.
Yeah,
So.
that's awesome.
Well, Rob, thank you for sharing a fresh perspective with us today. And, I think I speak for both Mike and I, where we both like your yes if approach as opposed to just a flat no. And so I think we've been able to share with the audience a different perspective on the implementation of AI in healthcare settings. But appreciate you being here, Rob, and maybe we'll have you back in 5 years once things shape up a little bit.
That'd be great.
Yeah, no, absolutely. And can I plug in that email real quick?
Oh yeah, absolutely.
Please.
Okay, perfect. So the email is rob@rpctconsulting.com, and they can reach out to me there. Also, can I do can I say hi real quick to my better half?
Yeah,
absolutely.
Thank you. I appreciate that, you guys. I hope that for the next 10, 20, 15 years that I make your feet happy, and you're my goalie, and she'll get it.
That's beautiful.
Rob, you're making Mike and I look bad over here.
I know. Now we're gonna have to do call outs to our better halves. No, that's
beautiful. Thank you for being on, Rob. This concludes another episode of the Next Orbit podcast. We'll see you on the next one.
The Next Orbit podcast requires more than a conversation. Be sure to subscribe, write a review, and share it with someone you think would benefit. Thanks for listening, and we'll see you on the next episode.